Good evening, everyone. We'll be starting in just a few minutes. We're just waiting for a few more people to join us. So I'm Dr. Sharita Golden. I'm a professor, vice president, and chief diversity officer for Johns Hopkins Medicine. And we welcome you to this community conversation about the COVID-19 vaccine. Sponsored by the Office of Diversity, Inclusion, and Health Equity. And this is a very timely conversation because it seems that every day there is a new development as it relates to our COVID-19 vaccines, and today is no exception. So we're glad that you're joining the conversation this evening. So what we're going to do is we're going to start out first by having one of my colleagues will present an overview of COVID-19 as well as what we currently understand about the COVID-19 vaccines that are approved for use now, as well as who's eligible for the vaccine. That has actually changed as of today. And then we will have each of our panelists given a brief conversation with you about what motivated them to get their COVID-19 vaccine, and then we will open it up to you all as our audience for a Q&A. So right now it's my pleasure to introduce Dr. Kaushar Talat, who is an assistant professor in international health in the Bloomberg School of Public Health. And she is also an investigator in the COVID-19 vaccine trials in our Center for Vaccine Research. And she is going to provide an overview of COVID-19 as well as the COVID-19 vaccines. So Dr. Talat.
Thank you very much, Dr. Golden.
We'll have you start sharing your video.
It won't let me. It says the host has disabled. But I will share my screen. Can you see my slides?
Yes, we can see your slides.
Okay. For some reason, it says the host has disabled my video.
Okay, I will check on that in the background.
So I'm going to go ahead and get started. Thank you very much for the opportunity to present about the vaccines. I will try to go quickly, but still be clear. So just want to reinforce that the things that increase the spread of COVID-19 and increasing individual risk are crowded situations, close physical contact, being in an enclosed space with somebody if you're unmasked, and the duration of exposure. So the longer you are with somebody, the more likely you are to have the virus spread if one of you has the virus. And then also to discuss who's at risk for severe COVID. We know that patients who are older, especially over the age of 60 or 65, males seem to be at higher risk than females. Anybody with pre-existing high blood pressure or diabetes, heart disease, obesity all by itself without the other risk factors seems to be a big risk factor for severe COVID. Some kinds of chronic lung disease is associated with severe disease, as well as cancer and chronic kidney disease. We also know that people of color are disproportionately affected by COVID. More cases occur, more hospitalizations, and unfortunately more deaths as well. So we know the ways to slow the spread of the virus. We can wear masks, we can stay at least 6 feet apart, we can wash our hands, we can clean and disinfect, but we can also use vaccines. And vaccines are an incredibly powerful and effective tool to help protect ourselves and our families and our communities from this very deadly virus. So I'm going to talk a little bit about the vaccines, and then I'll talk about vaccine safety. The goal of a vaccine is to develop an immune response to a virus or a bacteria. And we want that immune response to stick around. So you want to form a memory to that with that immune response. And you want it to be there months or years from now when you encounter that virus or bacteria, so that it lasts a very long time. And the most important goal is for that immune response to protect against disease when you're exposed to a virus or a bacteria. So you can have an immune response that doesn't protect, but you really want to protect against disease. An added bonus would be to protect against infection, but you really want people to not get sick when they're exposed to that virus. And we would like to also form herd immunity. Now, it's a little bit unclear whether it's even possible at this point to form herd immunity from vaccines from COVID because of the widespread nature of it, but it's sort of the ideal goal. And this is how it works. So if in a community, everybody is blue, that means they're susceptible to an infection when it comes into their community. And somebody who is in red comes into the community with that infection, they can then spread that virus to other people that they come into contact with. And those people can then spread the virus to other people that they come into contact with, and the disease spreads. And so the orange person is the one that had the infection and is either recovered or succumbed. But by the end, everybody in the community will either be red, they'll have the infection, or they'll be orange, that they've had the infection in the past and then have gotten better. The purpose of herd immunity is to create that protection, to create that memory in the population, so that before the virus even comes to you, the majority of people in your community are already orange, they're protected, they have immunity. And so when the person with the virus comes in, they don't encounter very many people to spread that infection to. So they may spread it to one person or to no people, but then that transmission stops. And so the people who are already protected can then act as a barrier to protect those who can't be protected, either because of an immune system problem or because of some other medical reason they can't get the vaccine, or they're too young to get the vaccine. So we can protect not just ourselves, but we can protect each other if we are all vaccinated. And depending on the contagiousness of a virus, sort of sets the level of how many people in a community or percentage of community needs to be vaccinated in order for that community to be protected. And so for a virus as contagious as measles, which is the most contagious virus we know, we need to have 95% of the population vaccinated in order to provide that herd immunity. For COVID, that number is a little bit less well understood, but we think it's somewhere between 70, 80 to even 85% of the population needs to be protected in order to keep us safe. So I'm going to now talk about the mRNA vaccines. They were the first vaccines to be licensed. This is the technology that is used by both Pfizer and Moderna. It was developed many years ago in order to respond to a pandemic just like this, because it's an incredibly fast technology to mobilize and to create and to make into vaccines. And the way that it's made is you take a coronavirus, which is down here in the right-hand corner. The red parts of the coronavirus are the spike proteins. We see those in all the pictures. The spike protein is what the virus uses to enter and invade our cells, but it also is this protein that in our bodies, our immune system responds to the most strongly. And so the mRNA vaccines takes just a little bit of the genetic material from the virus, the genetic material that codes for the spike protein. So it's not the whole virus. It can't give you COVID. It can't make you sick. And just the RNA for the spike protein, and it puts it into these little fat bubbles or lipid spheres or lipid nanoparticles. And the reason, and then it's injected in the arm. And the reason it's in these lipid spheres is because the lipids allow the mRNA to enter our cells. So here's our cell. The nucleus is where our DNA is. The cytoplasm is where the engines of our cells are, where we make our proteins. And so when the mRNA enters the cells, our protein engines, the ribosomes, take up the RNA, it turns it into proteins, the spike proteins, and then our immune system takes those proteins and responds to it and forms antibodies, and the T cells respond, and most importantly, it forms memory. So that when we are encountering the COVID virus, the SARS-CoV-2 virus, for the first time or the next time we see it, then we have all this antibodies and all this immune memory that and our body says, I know what this is, I know how to control it, and it controls the virus, and the virus can't invade our cells and it can't make us sick. So as I mentioned, there's two vaccines that use this technology. So Pfizer or the BioNTech vaccine is the first one. This one is given 2 doses, 3 weeks apart. This one's a little bit hard to get out into more rural and outreaching areas because it needs to be stored at ultra cold temperatures. But they're working on making it more stable. In the clinical trial, there have been over 43,000 people that were enrolled, and they tried to make the trial as diverse as the United States. So it's 10% African American, 4% Asian, 26% Hispanic or Latinx, 21% were 65 and older. In the trial, the vaccine was 95% effective for all people in the study, and 94% effective in adults 65 and older. And this initially received emergency use authorization for people 16 and older in December. And as of about an hour ago, it is now authorized for people 12 years and older. The other vaccine is the Moderna NIH vaccine. It's also an mRNA vaccine. It's given 2 doses 4 weeks apart. This one's more stable at regular freezer and refrigerator temperatures, so it's a little bit easier to handle. And their phase 3 study, there was 30,000 people enrolled, and again, very diverse populations. And this is 94% effective starting 2 weeks after the second dose. And this was also granted emergency use authorization in December, but for people 18 and older, because that's who the vaccine had been studied in at that point. They now have data for people down to 12, but it hasn't been authorized yet. It is normal to have side effects after vaccination, and that is just your immune system responding to the vaccine. So you can have pain in the injection site, happens in almost everybody. After they've been vaccinated. You can have redness and swelling at the injection site, especially after the Moderna vaccine. You can have redness that shows up even as late as a week or 10 days later, and that will go away by itself. You can have fatigue, headache, muscle aches, and chills are the most common sort of whole body responses. All of these are worse after the second dose, and all are worse in younger people rather than older people, again, because it's an immune system response. Those who are younger, their immune systems are more robust, and as we get older, our immune systems are a little bit less reactive, and so usually older people have fewer side effects. Fever can happen, especially after the second dose, and happens in about 15 to 20% of those who get the vaccine after the second dose. Oopsie. Sorry. These vaccines are incredibly effective, not just in the trials. We've now used the vaccines in the Pfizer vaccine has been given 140 million doses have been given in the United States, and the Moderna vaccine over 110 million doses have now been given in the United States. And so a lot of people have gotten these vaccines. They're incredibly effective. The CDC released some data recently that showed not only are the vaccines effective at preventing disease, but they're also very effective at preventing the carriage of the virus in our noses, which is important when we think about whether somebody who's been vaccinated could carry the virus and potentially spread it to somebody else. Well, what the CDC showed in 4,000 healthcare workers and first responders is that those who are vaccinated were 90% less likely to have any virus in their noses. And so so that's really good in terms of spreading the vaccine to spreading the virus to somebody else. Sorry, my husband's on another call. So then the vaccines are also very effective even in those who are older, for whom we actually have a hard time getting vaccines that work really well in them. And they've showed that in adults over the age of 65, the mRNA vaccines are 94% effective in reducing the risk of hospitalizations in a real world setting. So these are people, all comers, people with cancer, people with other comorbidities that could potentially decrease the risk of the vaccine working. The vaccines are still incredibly effective, which is fantastic. The other kind of vaccine that we have is the viral vector vaccines. This is the way that the Johnson & Johnson vaccine, which is authorized in the United States, or the AstraZeneca, which is not yet, but hopefully will be soon, but is the most common vaccine given in the world, is made. So they take a virus that an adenovirus, which is a cold virus, that they alter so that it doesn't cause disease. It doesn't. It can't cause. It can't cause the cold. It can't replicate inside of you. It can't divide inside of you. And they put the little piece of the genetic material for the spike protein in that adenovirus. In that adenovirus shell, essentially, but that adenovirus shell allows the genetic material from the spike protein to enter our cells, where again, this time it's DNA, so it's converted into RNA, and then the RNA is used to make the spike proteins that our immune system responds to. And so so again, it's the whole purpose is to get the genetic material from the virus, a little tiny piece of it, into our cells so that we make the proteins and we respond and we get immense, tremendous immune responses to these vaccines. So the Johnson & Johnson vaccine, or the Janssen vaccine, is a human adenovirus 26 vectored vaccine that has a spike protein. This enrolled over 45,000 people in multiple countries in their clinical trial, and they gave it as a one-dose vaccine. This is a very stable vaccine that can be stable for months at refrigerator temperatures and years at a regular freezer temperature, and it works really well. In the United States, the efficacy against moderate to severe COVID was 72%. That's basically the effectiveness of having a cold, but it was 85% effective against severe disease and 100% effective against hospitalizations and deaths. So it prevented both the colds as well as incredibly effective against being hospitalized and dying. The FDA authorized this vaccine at the end of February. There are side effects. They're very similar to the other vaccines, maybe a little bit milder. They're greater in young adults, 18 to 55, than in older adults who are 65 and older. Pain at the injection site's the most common. You again have fatigue, headaches, muscle aches, and nausea, and you can have some fever after this vaccine. So now that I've talked about the different kinds of vaccines, who should get the vaccine? It's everyone who's eligible, which is right now, everybody over the age of 16, although hopefully by the end of this week, it should be everybody over the age of 12. There's a limited supply, but the supply is increasing very quickly and should continue to increase over time. The vaccine should be free to you, so you should not be charged for getting the vaccine. Insurance companies may be charged an administration fee, but if you're uninsured, the government will pay for it, so you don't have to worry about that. If you have had COVID in the past, you should still get vaccinated, but you shouldn't get vaccine during the actual illness or while you're in isolation or quarantine. And the CDC recommends that you wait about 90 days after your illness starts. And that's because for the first several months after you've had COVID, you're really well protected against getting reinfected, but that immunity does go down over time. It doesn't create as good of a memory response. And the vaccine actually makes better immune responses than does having had COVID in the past, which is why you should still get vaccinated even if you've had COVID, because the immune response to the vaccine is even better. If you were sick with COVID and got monoclonal antibodies or convalescent plasma, you should wait 90 days after you receive it in order to get vaccinated, and that's just so that those antibodies don't interfere with the immunity that your body needs to create to the vaccines. In people who are immunosuppressed, we're not included in the trials, although there have been trials now that are looking at the responses of to the vaccines of people with all sorts of immunocompromised conditions. The vaccines are safe in people who have immunosuppression because they're not live virus vaccines. They don't replicate inside of us. They won't cause any disease. But what we will see is that the efficacy may be decreased, especially if the immune response is really weakened. Any protection is better than none. And so encourage you to, even if you are immunocompromised, if you have an autoimmune disease, you should still get vaccinated. There have been studies done looking at solid organ transplant patients, and they've had decreased responses to the vaccine, but some people are responding nicely. And so even people who are very seriously immunocompromised should still get the vaccine. For pregnant or breastfeeding women, the studies did not include pregnant women or breastfeeding women, but there's no known increased risk to the pregnant or breastfeeding women from the vaccine, again, because it's not a live virus vaccine. It doesn't cross the placenta and it doesn't cross into the breast milk. What does cross the placenta and into the breast milk are the antibodies that the woman makes to the vaccine. And so those antibodies can protect the fetus inside the uterus, and they can also protect the baby that drinks the breast milk. So it's actually a good idea to get vaccinated if you're pregnant or you are breastfeeding. The CDC recommends that pregnant people have the choice to be vaccinated, and pregnant women who will get vaccinated are being followed by the V-Safe safety monitoring system, which I'll talk about in a couple of slides. And there's been no signal seen as a safety signal or safety concern seen so far in the over 35,000 pregnant women who've been enrolled in V-Safe. And there's no difference in the safety of the vaccines and no effect on the pregnancy. So children, this is a very rapidly moving target. The Pfizer vaccine is authorized for those over the age of 16 and older, assuming, and Moderna and Johnson & Johnson vaccine are licensed only for those 18 and older. Now, the FDA just announced this evening that they're authorizing the vaccine for children greater than the Pfizer vaccine for children 12 and older today. The CDC will meet on Wednesday to decide if they should recommend the vaccine for children 12 and older, and I expect that they will. And trials are now ongoing, but for both Pfizer and Moderna for kids under 12, and hopefully by the fall, we will have vaccines for kids down to the age of 2. The safety of COVID vaccines is a top priority for those of us who are involved in vaccines and vaccine safety. This is a really nice infographic about how vaccines safety is monitored after it's licensed. So there's multiple different monitoring systems: the vaccine adverse event reporting system, the vaccine safety data link, and the clinical immunization safety assessment project. And I'm going to talk about a couple of these. The first is a new one called V-Safe. I mentioned it with the pregnant women. V-Safe is a new smartphone-based monitoring system for healthcare workers who are receiving COVID-19 vaccines to record adverse events after vaccination. And so when you get your vaccine, you'll get an information sheet about V-Safe. You can download the app, you can snap the QR code, and you can enroll in V-Safe, and it will, they'll ask you every day for a week after each dose of vaccine what kinds of symptoms you have, and then it'll ask you weekly for a year if you've had any health problems or what kinds of symptoms. And so it's a really good way of tracking large numbers of people, and there are several million people who've now enrolled in V-Safe, and you can monitor the safety. And it's very similar to what we saw in the trials, that these vaccines do cause side effects in the day or two after vaccination. They can cause fatigue, sore arm, sometimes fever, headaches, muscle aches, etc. But they go away pretty quickly, and after that, there doesn't seem to be any problems. But there are people who should not get the mRNA vaccines. And one of the things that we found with our monitoring system is that there are allergic reactions, and very rare allergic reactions, that happen after the mRNA vaccines. And so, and this was detected by our vaccine adverse event reporting system, and it still continues to be monitored. So the people who shouldn't get an mRNA vaccine is anybody who's had an immediate or severe allergic reaction after a previous dose of an mRNA vaccine. So if you have your first dose of Pfizer or Moderna and you developed hives right away, or you started having problems breathing, or your tongue swelled up, any of these things, you should not get the second dose. You can get the Johnson & Johnson vaccine instead. Anybody who has the same sort of immediate allergic reaction to polyethylene glycol or polysorbate should not get these vaccines. And anyone with these reactions should see an allergist to evaluate for what vaccine is safe for them. Anybody with other kinds of allergies can get a vaccine. So anybody with an immediate allergy to another vaccine, an injectable medicine, or a history of anaphylaxis, but we just ask that they wait for 30 minutes after the vaccine, or you can talk to your doctor first. And these severe allergic reactions do happen. They can happen after any medication or any vaccine. The rate's a little bit higher than we saw with other vaccines for the mRNA vaccine. So it's 1 in 200,000 doses of the Pfizer vaccine, somebody will have a reaction to it, or 1 in 350,000 doses of the Moderna vaccine. which is why we watch everybody for 15 minutes. And again, if you have those allergies to other things, you should wait for 30 minutes and just be monitored after your vaccination. And all vaccination sites have to have epinephrine at the site in order to treat them, because this is a very treatable condition if it's treated early, but can be potentially life-threatening if it's not. And so I'm going to finish our safety section by talking about the safety updates for the J&J vaccine. So on April 13th, the CDC and FDA paused the use of the J&J vaccine while investigating 6 cases of rare blood clots that are associated with low platelets. So this is something called TTS, thrombosis and thrombocytopenia syndrome. Thrombosis is a blood clot. It can happen in a vein or an artery. When it happens, it can stop the flow of blood to those areas and cause some significant problems. The 6 cases, it was women who had clots in their brain, and it was also associated with low platelets. Now, clots are not an uncommon thing, but this association of the blood clots with low platelets, which are the cells that are involved in clotting in the blood, was what was sort of the signal that triggered that there may be a safety issue. The pause allowed the CDC and the FDA to collect more cases, allowed for dissemination of information to all healthcare providers, hospitals, patients, the public, so that people who had these symptoms would come in and say, or had patients with these symptoms would say, hey, I have a patient with this, and collect as many cases as possible. And then the CDC met again on April 23rd and had another emergency meeting and evaluated this. And so by April 23rd, there had been 8 million doses of the Johnson & Johnson vaccine administered in the United States. There were 15 cases that had been reported to the CDC of this rare thrombosis and thrombocytopenia syndrome. Most of them were in, actually all of them were in women under the age of 60, so between the age of 18 and 59. The symptoms developed 6 to 15 days after vaccination. And most people who had this happen started out with headache as their most common symptom. Now, it's very normal to have a headache right after vaccination and a day or 2 after vaccination, but it's really unusual to have that headache go away and come back a week later and then not go away and get worse. And so if that happens to you after you've had the Johnson & Johnson vaccine, you should seek medical attention, because if you catch it early, it is very treatable, and you don't have to, it won't have the devastating effects that will happen, that can happen if it's caught late. We have not seen the same kinds of blood clots with low platelets among the more than 230 million doses of mRNA vaccines administered, but it has been seen with the AstraZeneca vaccine, which is very similar to the Johnson & Johnson vaccine. And because of the rarity of this and because the benefit from the vaccine, the CDC and FDA decided to lift the pause after we've all sort of been warned about this, and people, when they're offered the vaccines, should be able to have a choice of vaccines and decide which vaccine is best for them, knowing what the risks are. Because COVID is a much more deadly disease than these very rare clots that are associated with the vaccine. And the other really good thing that happened is that the fact that such few cases, 6 cases, triggered the pause. The fact that we were able to identify 6 cases and detect them showed that our vaccine safety surveillance system is working. I mentioned that there were 15 cases. They were all women. Since then, there's been at least 1 case in a man. But it's still a majority of these cases are women under 60. There's a few things that we still don't know about the vaccines. We don't know how long the protection will last. We don't know if the boosters will be needed, especially with the variants. We know that it decreases our ability to carry the virus in our noses, but we don't know if it'll prevent any asymptomatic transmission or infection at all. And there's still subpopulations that we're learning about the efficacy of the vaccines in, such as people with immune compromising conditions. And so in the meantime, if we're around people who are not vaccinated, it's still important to wear a mask and protect others. I'm going to skip this slide. So there's a lot of positives that you can do if you've been vaccinated. So you can gather indoors with other fully vaccinated people without wearing a mask. You cannot wear a mask when you're outside. If you're traveling in the US, you don't need to get tested before quarantine or after travel, and you can be reassured that you are protected from the severe consequences of COVID. And so there's a lot to be said about getting vaccinated so we could go back to having our normal lives. And that's it. And I'll stop here.
Right, thank you, Talat, for that very comprehensive overview, and for even updating it right up until the last minute with the news flash right before we started. So always appreciate your very comprehensive overviews. And so before we move to our Q&A, I just want to introduce our other panelists and just have each of them just indicate what it was that motivated them to get their vaccine, because I think for many of us who still have questions, it's figuring out what is the why in our particular lives or situation or circumstance that really makes it important for us to be vaccinated. And so I will start and say that for me, it was my parents who were blessed to turn 85 in 2020 during the pandemic. And I felt like I spent most of the better part of a year just trying to do everything I could to keep them alive, like incessantly washing hands, masking, distancing when I went to assist them with things. And so I thought that it was really important for me to be protected as a part of their caregiving team. And so it was almost like, doctor, put your own oxygen mask on first so you can then assist others. And so now that I have been vaccinated and they have been vaccinated as well, now we can go and we can sit and we can, eat dinner together without the masks and feel more comfortable. And so, I think for each of us, we have to figure out, what is the why? And now my whole family's vaccinated, my husband, who's also a physician, and our son, who's about to graduate from college. So we'll be able to actually go to his college graduation in person. So they're just, there are things to think about, but who else in your life other than yourself do you really feel strongly about protecting, as thinking about your motivation? So I will next introduce Dr. Kathleen Page, and I'll ask each person to turn their camera on as I introduce them. She is an associate professor in the Division of Infectious Diseases and also the director of our Total Access Program and our Health Equity, Latinx Health Equity Champion in our office. And so just Kathleen, have you just say what your motivation was, and maybe specifically as that relates to your community?
Yes, hi everyone, and thank you for joining, and thanks Sharita for having me. So I was, I think, vaccinated for a couple of reasons. One of the main reasons was actually being able to tell my patients that I was vaccinated. As a healthcare worker, I got offered the vaccine earlier, and although I maybe wasn't in the highest risk category in terms of age and other things, I did think it would be important, and it was, to be able to tell my patients, many of whom are immigrant, to sometimes mistrust the health system, that I had gone. The other reason for me is my family, most of my family is in Latin America, and Latin America has suffered greatly from COVID-19. And the vaccine is actually still not available to most of my family members, including my parents. And so it was a little bit embarrassing to even think about declining the vaccine here when so many people are really desperate for the vaccine all over the world. So I felt like it was my obligation to get vaccinated. And then as an added benefit, really after being vaccinated, I have felt like Sharita that I can do more things, visit some friends that I hadn't seen for over a year, and really feel more comfortable and safe around people that I know and love and had missed a lot.
All right, great, thank you. And Dr. Ambani Sweenor, she is an associate professor of ophthalmology and is the director of the Center for Disability Health Research. And I'll have her share.
Hi, thank you. Yes, thanks everyone for joining. Like Dr. Page and Dr. Golden, I was vaccinated for multiple reasons. I have 2 small children, not yet 12, so we'll be waiting a while for them to be vaccinated. and protecting them as best I could was important. But my research is about advancing health equity for people with all different types of disabilities, and I do that work because I myself have a disability. I'm visually impaired, and because of that, I no longer drive. And so to get where I need to go, I take public transit or ride share. And getting a vaccination was important because in those situations, you don't really have a lot of choices around those who are around you and their decisions about masking themselves. So that was a huge factor in my decision to get a vaccine.
Thank you so much for that. And Dr. Quentin Piggott is an associate professor in our Division of Infectious Diseases and also our assistant dean for biomedical graduate student diversity. So Dr. Piggott, who's also on clinical inpatient service right now. So we are so grateful he could join us for a few minutes.
Thank you, Dr. Golden. And so thank you very much for having me for this session. So for me, in terms of thinking about the vaccine, over the last year, I've gotten many calls and many conversations with patients, with family, with friends, with many loved ones around COVID in many different ways and the impact that it's had on their lives and the impact it has had in terms of the connections that we've had with all our loved ones. And I think for me, being able to know that vaccines have been life-saving for so many years as an infectious disease doc, appreciating how much from young till now that vaccines have had such a positive impact in terms of making sure we can enjoy the lives that we love with our family and loved ones is one piece. The thinking about just how much this illness has impacted so many as well, and in sort of respect to those folks as well, it's been another piece for me as well. And I think just wanting to get back to, as everyone has said, to a life where I can hug and just connect again with all those folks around me. So I think all those things together, there have been many questions that have come at me from friends and family and patients about, should I get this, should I not get this? And I feel for me, it would be hard to talk through with folks considerations, the merits and demerits of getting a vaccine without having gone through it myself, ultimately. And so I had to take a hard look at the data and to make some decision as to, based on that data, what are the benefits and the risk. And for me, as I talk to family, friends, and patients, for me, the benefits were much more than any potential risk that existed. And so that's why I decided to get a vaccine.
All right, great, thank you. So we'll have all the panelists turn their videos back on because we're going to move to the Q&A. And as we're moving to the Q&A, Dr. Talat, would you like to share your motivation for getting the vaccine? Given that you were one of the research scientists very much involved in generating the data that were just shared.
So I've been working on vaccines for 14 years, and I worked on the AstraZeneca and the Pfizer vaccine trials for the COVID vaccine, and so I had the opportunity to join the Moderna study and sort of putting my body where my mouth has been for 14 years. And vaccines are great, and we need the true heroes in public health are the volunteers who volunteer for the study. So we have these data so that we know that vaccines are safe and that they work. And I admire the people who volunteered for my studies for many, many years. And so I got to be a volunteer. It's very exciting.
Well, that is awesome. And I will say, for those of us who are clinicians, the other value of being vaccinated is we can actually go out into the community and help vaccinate our fellow community members. So I think for me, that's been like another benefit that's been very exciting. So So we're going to move to some of the questions that you put in the chat. Some of them we may have answered during the presentation, but if not, we can get to them now. So the first question is, are there any studies on future shots or boosters to determine if you received one type of COVID-19 vaccines, let's say J&J, and boosters become available, will it be like, would you need your booster with the same vaccine brand that you got your first shot with? Or is it going to be like one booster, each of the series going to have their own booster? And do we have any information about that currently?
The studies are ongoing right now. So we're looking at boosters with the same vaccine and also boosters with a different vaccine.
Okay, great. So hopefully we'll have information on that by the time we might potentially get to that point. So this is a very dynamic process. So the other question is, would the vaccine be contraindicated with chronic ITP? So that's idiopathic thrombocytopenic purpura.
So it is not, and in fact, it is recommended with people with ITP. There is an ITP society that is actually doing a registry of patients who have chronic ITP and asking them to register when they get their COVID vaccine and have their platelets checked before and after, just so that they gather more data for larger groups of people. But there is no, they're absolutely indicated for people with ITP, and then, yeah.
All right, great. So this is another question. Should a breastfeeding mother of a 1-week newborn be vaccinated, and which vaccine would be most appropriate for a mother with a low platelet count? So 2 questions in one there. So there's one about the breastfeeding if you sort of have a very young infant, and then the other question is about is there a vaccine that's more appropriate for a mother with a low platelet count, which may have just been answered, but.
Yeah, so absolutely you should get it with a low platelet count. In terms of yes, as a breastfeeding mother with a 1-week-old, you should still get the vaccine. Which vaccine is best for you depends on your personal preference and your risks and benefits. Again, the people who have the risk, the people who have the highest risk of the very rare clots with the J&J vaccine are women who are between the ages of 18 and 60, and the 2 mRNA vaccines don't have that same risk, but that risk is very, very rare, and the J&J vaccine is sort of balanced out by being a 1-dose vaccine, and so you don't have to go back a second time. So that it's up to you and in discussions with your physician as to which vaccine is best for you, but there are pluses and minuses to both kinds of vaccines.
The next question is, do we have data regarding the average number of adverse reactions and some vaccines we already know? So in other words, comparatively speaking, what is the sort of a side effect profile of the COVID-19 vaccines compared to others that we, commonly get?
I will let my colleagues answer what they think. I don't know. I think.
Yeah, I don't know. I'm just thinking about it's Kathleen, Dr. Page is unmuting, but thinking about the flu vaccine or some of the others, interestingly, I feel like we have a lot more data that we're monitoring on these vaccines because they are so new that I don't know that we sort of monitor in as rigorous detail with some of our other vaccines that have been commonly used for years as we're doing currently with these, but see if any of my infectious disease colleagues have any other thoughts about that.
I have not seen any head-to-head comparison. I think you're absolutely right that there's a little more attention on this and how people are reporting. My gestalt, although again, I'm not sure this is good enough information, is, for example, the sore arm to me is comparable to tetanus vaccine, which many people get a sore arm with that. And so that seems to be a good point of reference. There may be a little bit, with a flu shot, it's common that people say, I feel like I got the flu or I got a flu-like syndrome, but I don't have actual percentages of that. So it may be comparable to that in terms of the flu-like illness, but I don't have any hard data. I don't know if Damani or someone else has seen that.
Yeah, I also not, in terms of direct head-to-head comparisons, I'm less familiar with. I would say though that the system, at least some of the systems that have been deployed to monitor vaccine potential effects are actually systems that existed for other vaccines, right, for a very long time. We were able to superimpose upon that structure to be able to keep the rigor in which there are folks in the national space who are looking at the effects of vaccines and making sure everybody's safe, right? That rigor has happened for a very long time with all our other vaccines as well, and we're able to use that for COVID. So that is what I would say.
Mm-hmm. But I think in general, like the feeling of like the sore arm, feeling achy, you know, interestingly, because this had been discussed, because often when you get the flu shot, I don't think that we get a sore arm and think, oh, okay, well, that's to be expected. But, you know, when something is new, you know, we have much more focus on it. So honestly, I felt that the side effect profile, at least for me and my family who got, especially my older family members who've gotten the vaccine, that they had like fewer side effects. They tolerated actually better than the flu shot in many instances. And so, you know, now in terms of like the rarer things that we've seen, like the question with the blood clots and things like that, hard to know in terms of head-to-head comparison with other vaccines, again, because people may or may not be monitoring and thinking necessarily about, I got, you know, like a shingles vaccine or a tetanus shot like last week, and now I have these symptoms, because, you know, again, things are being monitored much more closely currently.
The only other comment I would say is that with a 2-dose vaccine, that's a little different from flu shots, where we give one dose every year. And for some people, that second dose can create a little bit more of a, you know, again, nothing serious, but a little bit of a reaction. And so that's just something unique, you know, unique to having 2 doses. But overall, I guess the reassuring thing is first of all, the Madness and Dr. Tala talked about, there's really strong monitoring systems. The fact that we identified that very rare side effect for Johnson & Johnson, I think speaks to the strength of that system. Really, you know, we're talking about very rare cases that if we did not have that robust way of monitoring things, we would have never found out, really. That gives us confidence in the system. And then the next step is that with that robust system, that's really the only serious side effect that has been identified. Everything else is a little uncomfortable, but it's nothing serious, and it goes away in a day. And it's certainly a lot better than getting COVID.
Yes.
I think Shingrix is probably the only vaccine that I can think of that has a similar, and only for people over the age of 50, but it kind of knocks you out after the second dose in the same way. But again, head to head, like everybody else has said.
So this is another question related to persons who had blood clots with the J&J vaccine. Were they individuals who were smokers, a history of blood clots, birth control pills? I think you may have gone through some of that in one of the slides, but maybe we could just review that one more time.
So again, they were majority women, not all women, and they did not all have risk factors. So obesity was present in a few of the women. 2 of them were on birth control pills. I think 1 was a smoker. So, and the vast majority had no family history or no personal history of having clots in the past. And this is a little bit different than the regular likelihood to clot that can happen in a woman who takes birth control pills, because if you are birth control pills, or if you smoke, you have a much higher risk of clotting. These clots are a little bit different because it's an antibody, it's an immune process that's causing the clotting and the low platelets. And so we don't know yet if those traditional risk factors are risk factors for having those clots with the Johnson & Johnson vaccine.
And then this is another question. As I understand it, the J&J vaccine is comparable to the more traditional vaccines. Is that accurate? And perhaps our audience members are referring to the technology used, perhaps as being more comparable.
It is and it isn't. We've had other viral vector vaccines. Yellow fever is the one that's most commonly used. Actually, it's a live attenuated virus. And the Ebola vaccines are very similar technology to the J&J vaccine, but it's not something that we use in our everyday childhood vaccines or routine vaccinations. It's still a relatively new technology that's being used for pandemics because it's so much faster than our normal vaccines and our traditional vaccines. And I have to say that the companies that were making the traditional vaccines, several of them, the vaccines failed in early trials. And we may not have a traditional normal vaccine for COVID.
And in fact, these may become our new normal types of vaccines because the technology has been able to be evolved quickly for very acute public health crises. And then I also, in doing some reading, understand that mRNA vaccines are now being considered for cancer vaccine trials and some others. So there's ways that this will expand. I do want to direct a question to Dr. Sweanor, just to ask, you know, in the disability community, what are special considerations with regard to getting vaccinated? You know, who should be vaccinated, and you know, and making sure that they have access to the vaccines.
Yeah. So the Disability Center gets this question a lot. So there's no data really showing that people with disabilities are having more adverse events than people without. So there's no suggestion that there shouldn't be getting vaccine. But as you indicated, there are challenges that we know about in getting to vaccine and getting information about vaccine that still persist. And there's efforts underway, both from the federal government as well as at state levels and local levels, to address those challenges. So there's gaps in the accessibility of information about where vaccines are, where you can go to get a vaccine in your local area, the accessibility of the registration to register for vaccines when that's still required, although that's changing rapidly into not being needed to be required. There's difficulty in getting transportation to vaccine for people with disabilities. That's being largely acknowledged as a barrier that needs to be addressed, and accommodations for certain individuals at the vaccine site. And so that includes people who are wheelchair users, people with sensory disabilities, as well as a larger umbrella of individuals who maybe need different types of accommodations. This is a discussion that's being had, and lots of vaccine locations are doing their part to make change. And I've seen an important shift over the past many months. It's, if possible, I think advisable, if you have concerns, to call ahead if that information isn't present at the location you're trying to get a vaccine, if you have an accommodation request. And for the transportation gaps, there is efforts about to be rolled out, again, at a local and state level. And so stay tuned for folks that need assistance there.
Great. No, very, very important information to consider there. So are there any additional questions? We don't see any more in the Q&A box. So just want to make sure there aren't any additional questions. So someone says they do. Okay. You want to go ahead and type it in the Q&A in the box. It's not like a text. It's hard to tell if someone's typing actively. So we'll wait a few more minutes. Just while we're waiting for that last question, is there anything else that any of our panelists want to just share with the audience for further consideration? Okay, so this is a good question. So hearing impaired individuals are concerned about losing hearing with taking the vaccine. Is there any evidence that that there could be a hearing impairment related to the vaccine?
Yeah, I've gotten this question before too. So I haven't seen any data that shows that is really the case. And I know there is some discussions among the community of people with hearing loss that may be an outcome, but there's really no data to substantiate that. And in fact, I would argue that for people with disabilities, including individuals with hearing loss or people who have hearing impairment, there's potential for increased risk of COVID because of the way that you interact in society that may put you at greater risk, meaning standing in closer contact with individuals to communicate. And so to me, that's a compelling reason to get vaccinated.
Right. And also, you know, if you have the need to lip read, then it requires people, if they don't have the clear mask, to remove their mask. So again, that can be another risk factor for obtaining COVID. So any additional parting words that any of our panelists would like to share? This is another question related to hearing. So if you have a patient with vestibular disease like Meniere's, is there a concern about an increase in symptoms? You know, so like vertigo, tinnitus, which is ringing in the ears or anything like that. And I haven't seen data to support that, but just wanted to verify with my other colleagues.
I haven't seen any data either.
No, me neither. I would also defer to my colleagues.
Yeah, I would just say that, you know, this is a question I get a lot generally, that people who have comorbidities, who are, you know, they have diabetes or cancer or whatever, are a little more worried, and understandably so, because they already have, you know, other health issues to address. But actually, you know, this is a group that really needs to be vaccinated, because the risk of severe COVID and death is much, much higher in people with comorbidities. And in fact, as Dr. Talat said, there's really only one contraindication, and that is having had an allergic anaphylactic reaction to the first dose of one of the vaccines. Everyone else really can safely take the vaccine, and we have data not only from the clinical trials, but now from millions and millions and millions of doses given to a very diverse group, which really are really reassuring that the vaccine is safe, and it's safe in all groups, including those with comorbidities.
Yeah, and the trials were intentionally enriched to include people with disabilities, comorbidities, people over the age of 65. And so again, the populations that were being most impacted. And so, you know, I know at least like in the Pfizer and Moderna trials, about a third of the trial participants had some type of comorbidity. So it really was a population that looks like looks like our community and the people who have been impacted by COVID. So I think that's all reassuring. And then there's one more question is, do any of us have any knowledge of trials going on for treatment of COVID-19 with ivermectin?
Yeah, so there has been a phase 2 trial done with ivermectin, but I think we're waiting sort of larger, well-designed trials to determine further the role of ivermectin. I think right now there may not be quite data to recommend for or against.
Okay. All right, great. And this is another question, and this is a common, you know, concern that people are concerned about their DNA being changed, and this is likely in reference to the mRNA vaccine. And can we reassure that this is not the case?
Yes.
Yes, and I think that's
I was going to thought. Yeah. So these vaccines do not change our genetic code or our DNA, our imprint. This is appreciably understand why folks might have that consideration, because when we hear about genetic code about the vaccine, but these do not change us and change our DNA and who we are.
Because it's basically giving you the mRNA so that your body can make the little spike proteins. So coronavirus is called, because corona means crown. So all those little spike proteins that stick up and make it look like a crown. And so it's really giving you the mRNA to be able to make that protein. Once you've made the protein and your body's made the antibodies, your cells like break down the mRNA. And that actually happens even when we're taking our own DNA and making proteins from our own DNA. Eventually that messenger RNA gets broken down. So that messenger RNA doesn't go into the part of your cell that has your DNA. It's sitting out in this fluid around that, and it gets broken down right after. So, basically it's not like changing your blueprint in any way.
Yeah, I don't know if there's any younger people out there, but it's been described to me as a Snapchat message. So the message tells you what to do. And Snapchat, for those who are familiar, is a message that then disappears. And so mRNA does that. It goes in, it tells the cell what to do, and then it goes away. It doesn't stay there permanently. Or if you don't use Snapchat, it's like a text that was deleted or something, but it is really temporary.
I like the Snapchat analogy as the mother of a young adult who uses that. And then you ask, can you see it? And it's gone. So it does. It's just enough like of a snapshot so you can make that antibody. So then the next time your body sees that, your body says, oh, wait, this isn't a part of me. This is something foreign. And it stimulates you to make the antibodies to fight that coronavirus the next time you see it. So that's a great analogy. So I hope that answers the question, because that's a very common question. Well, if there are no additional questions, we hope that this has been an informative session for everyone. We are recording, so we will be able to make this recording available, and really hope that we've been able to not only answer your questions, but help you to motivate you to think about your own personal why, or helping those in your lives who are still making decisions to determine their particular why. So we thank you for spending the evening with us, and look forward to future programs. Stay healthy, still wear your mask, stay socially distanced, particularly for those who are not vaccinated, and continue to wash your hands. Thank you very much.